Good morning, Mr. Chairman, ladies and gentlemen. Here is the slide referring to conflict of interest, and now let's move on to the presentation. The current situation regarding out-of-hospital cardiac arrest is that the percentage of bystander CPR has remained very low, about 30% of the witnessed cardiac arrest over the years. Literature offers two main reasons for this. The first one is lay people's fear of performing CPR, due to, for example, fear of infection, fear of not being able to do it, fear of harming the patient, and fear of legal consequences. The second one is lay people's lack of knowledge of the CPR technique. So, a way to try to improve the number of bystander CPR is to train more and more people in CPR. We have also to consider the ILCOR 2010 guidelines. In particular, they stress the importance of teaching high-quality CPR, that is CPR with compressions of adequate rate and depth, allowing full chest recoil between compressions and minimizing interruptions in chest compressions. The guidelines also advise that training should focus on ensuring that chest compressions are performed correctly. So, combining this evidence and these recommendations, it is clear that we must train more and more people, not just in CPR, but in high-quality CPR. So the question is, mass training is the solution to the problem? What do we currently know about mass training? We know that it is a way to train lots of people at the same time, and it is more attractive for senior citizens and for relatives of cardiac patients than standard BLSD training.
Yeah, that's true.
But we don't have any information about the CPR quality of the participants after a mass training event. So the purpose of our study was to assess chest compression quality after mass training in comparison to that resulting from classic BLSD training. Regarding the methods, we enrolled 190 lay people, aged between 18 and 35, who had never previously attended a CPR training course. 55 of them attended a mass training event, and the other did a standard BLSD course. And in this chart, you can see the main differences between the two types of courses. In mass training, every student has a personal mannequin, whilst in standard BLSD course, the mannequin is shared with 4 other people. In the first type of course, there is one instructor for every 15 students, whilst in the second, there is one instructor for every 5 students. Theory is given 30 minutes in mass training, and it is 1 hour in standard BLSD training. And practice time is 45 minutes in the first one and 4 hours in the second one. The last important difference is that in mass training we use a low-budget inflatable mannequin, whilst in standard BLSD training we use a much more expensive standard BLS mannequin. At the end of both courses, we use a mannequin connected to the PC to analyze 1 minute of compression-only CPR. In particular, we consider the number of compressions per minute, the percentage of compressions with adequate depth. By adequate depth, we mean a compression with a depth between 5 and 6 centimeters, as stipulated by ILCOR 2010 guidelines, and the percentage of correctly released compressions, meaning a compression with full chest recoil at the end. So let's look at the results. As you can see in these charts, there was no statistically significant difference between the two groups for the correctly released compression percentage, 96% versus 94% respectively, with a p-value of 0.36, and for the percentage of compressions with adequate depth, 89.1% for the mass training group versus 76.7% for the standard BLSD group, with a p-value of 0.54. But there was a difference for the number of compressions per minute, 115 for the mass training group versus 120 from the standard BLSD group. And here we can see that mass training groups, considering the confidence interval, adhered more to the guidelines. In conclusion, we can assess that mass training is at least as effective as classic BLSD training according to all the parameters analyzed. And furthermore, mass training attendees reach the compression per minute target more often than those on BLSD courses. This fact could be due to the continuous use of a personal mannequin instead of interrupted training on a shared one. Considering the results of our study, mass training achieves the goal of training more and more people in high-quality CPR. In practice, if you have 5 hours and 3 instructors available, with a standard BLSD approach, with 1 instructor for every 5 students, and considering a course duration of 5 hours, according, for example, to the Italian law, we could do only 1 session of the course, training only 15 people. On the other hand, with a mass training approach, considering an instructor-attendee ratio of 1 to 15 and a course duration of 75 minutes, we could do 4 sessions of the course, training in total 180 people in high-quality CPR. A great difference. And what could the future implication be? We think that if the mass training approach were more widespread and encouraged, there would be numerous advantages. Firstly, we would rapidly increase the number of people training in a high-quality CPR. Secondly, we would save time and money. And thirdly, we would attract a greater variety of people. So translating these considerations into practice, mass training could increase the incidence of bystander CPR and so the survival rate after out-of-hospital cardiac arrest. This study was carried out by the non-profit association Pa' Via nel Cuore, which was founded by myself and other friends 1.5 years ago in order to spread the knowledge of CPR amongst the people and improve the number of EADs available to the public in our region. So this last slide is to thank all the volunteers who made it possible. Thank you for your attention.